Our next speaker is Soumya Choudhary. She's a dedicated researcher and digital mental health expert, currently pursuing a PhD in psychiatry at the National Institute of Mental Health and Neurosciences at Bangalore, India. She's also a visiting research fellow at the Division of Digital Psychiatry, BIDMC, Harvard Medical School. Soumya holds a master's degree in mental health research and practice from the University of Nottingham, where she specializes in clinical psychology, neuropsychiatry, and artificial intelligence. At the NIMH-ANS, Soumya has been involved in Wellcome Trust-funded projects such as the SHARP study, which focuses on smartphone-based assessments and relapse prevention in psychosis. Her research integrates advanced data analysis techniques and app-based interventions to enhance mental health care. Soumya has also published extensively in the field of digital mental health, with works exploring digital interventions, machine learning applications in mental health, and relapse prediction in schizophrenia. Soumya is passionate about scaling digital mental health solutions globally with a focus of low and middle income countries. So everyone welcome Soumya Choudhary.
Thank you, Kate. Thank you, John. I'll just start by sharing my screen. So thank you, Kate, for the introduction. I'm going to try my best to stick to the time and cover this vast topic. Good morning, good afternoon, good evening, everyone, from whoever is joining from whichever part of the world. I'm Soumya. I'm going to be tackling a heavy topic in the shortest time possible. So let me try to cover what I have learned from my experience of conducting digital mental health in LMICs, which has been my passion, frankly, since I started studying psychology. What is an LMIC? When I was talking about this talk with my peers and I put it up on LinkedIn, I got some messages saying, what exactly is an LMIC? So LMIC is for my vast audience, it actually stands for low and middle income countries. And this is a classification given by the World Bank based on the gross per capita income of the population that lives in it. So the countries that come under this category are those where the majority of the population have a lower and middle income range. And it is a classification that is updated every year. Currently, India is a part of this list, but we also have other countries like Brazil, Nepal, a lot on the southeastern belt, etc. I have been here all my life, and what we have tried to do is to see how best can we adapt AI in a country that has rapidly expanding digital access, which makes it very it's almost like a fertile ground for AI applications, and also in terms of the treatment gap that we face, making it the perfect environment for us to use these solutions. AI, some of the points that you see on the screen are the reasons why AI in LMICs. So we do have the rapid digital expansion of technology available here, but very limited evidence. You might wonder that there are a lot of studies that are coming out of the LMIC belt, but they all are either pilots, with very small sample sizes. They are cross-sectional, they don't have long-term data, and they are also not very sustainable in terms of like what happens after the pilot is finished. And the even pooled reviews talk about moderate evidence for AI-based methods only in identifying risk factors and developing and delivering some form of treatment, not for long-term monitoring, not for bridging any treatment gaps, not for helping with the mental health access, the ones that are the very need of the hour. We will talk more about it in the coming slides. And AI can thus address the severe mental health workforce gap, but countries like India and others lack the infrastructure for sustaining such technology. And when I talk about infrastructure, I would mean like for example, the server costs that are needed, the server space that is needed, the training that is needed, for the efficiency that is needed, etc., to deploy such solutions that we try to adapt from the West. It becomes challenging, and therefore it cannot just be a handed down solution. It is something that has to be made very specifically to an LMIC environment. And based on all the research that I have done, I have seen, I have read, hybrid models with human support are going to work best in terms of AI or any other form of digital mental health in an LMIC setting. Now, this is a very interesting list of the dimensions that I made when I was trying to think about what really has been the difference of comparing my time when I visit the BIDMC labs and when I come back taking that knowledge and try to adapt it to an Indian setting. These are the dimensions that I see are actually the most critical in adapting a technology from place A to place B. If I can give you an imagination, like I work at a setting which is it is the largest tertiary care institute in the country and a public mental health hospital in the country. It has high patient volumes. It has very limited like patients with very limited digital literacy. They come from all socioeconomic backgrounds. They come from all linguistic backgrounds, and there is a patient load of about 1,000 to 2,000 patients per day over the course of 9 to 5 OPD hours that we have. In such a busy clinician environment and clinical setting, how do we apply AI that can actually help the overburdened clinician and not like put more work to it, and can actually help the patient who's just sitting there waiting, follow up after follow up? How can we provide them long-term care when they go outside of that setting? So the things that I've learned is the digital infrastructure is not the same in an Indian context. Here we do have a lot of smartphone penetration, but we have one family will have one phone. So who is going to use that phone? Whose data are we getting? The shared family phone concepts is something that is very unique to this belt. And it is hard to explain to funders outside that we are having difficulties in onboarding patients because the whole family has one phone. So we need to have AIs that are, we cannot have a solution that is unique to the patient because it is a shared phone. So there is smartphone adoption, but it is unique to every patient. As compared to in high income country, there is a mental health workforce shortage. I have seen that AI in the West is mostly used for filling the product or addressing the productivity gaps. Here we are trying to we want to use it to address the access gaps, where they can use this technology a patient can use this technology to bridge the gap between a follow-up and their waiting period. Data quality and availability, the AI here has to be robust to missing data, because yes, there is a smartphone, yes, there is internet, but it might not be a high bandwidth internet. So the data that you're going to get is going to be very fragmented. So the technology and the models have to be very robust to missing data. Just because somebody would own a phone, that doesn't mean that they would know how to use it. And that is why it would become, the concept of digital literacy becomes more vital to such settings. And definitely cost and resource constraints are something that I feel like even a higher income country would face, but it is more critical here because we would need to invest in a frugal solution, but that is something that is more efficient. And rather than focusing on the sophistication of the software, we would focus on just the efficiency of it, but it being simple enough for people to be able to use it. Now, these are some of the insights that I would like to share about our collaboration with Dr. Doris's team at BIDMC and a study that was funded by the Wellcome Trust back in 2021. We have gotten refunded recently, last 2 years ago, and this is about smartphone health assessment and relapse prevention using the MindLamp app. And over this course of last 4 years, going into the 5th now, we've been trying to see whether these digital tools are really as efficient as we have been reading about. And yes, it is. And these are some of the insights that we have generated. First is that digital phenotyping is not the first question that we wanted to answer is, okay, so the digital tools are expanding. There is a term called digital phenotyping that is coming up. Is it is useful in common mental health disorders, yes, we know, but is it also equally helpful in severe mental illnesses like schizophrenia? Is it feasible? We found out from our studies that it is feasible to collect longitudinal data from patients with schizophrenia using a MindLamp app, not just in the West, but also very much in the East. We had two sites in India, one urban, one rural. I was from the urban side. We had our colleagues from the rural side, and we got um, equally dense data longitudinally over a period of 1 year from all the three sites, the urban setting, the other high income setting being in Boston. The other critical point that we realized is that digital navigator is critical to any digital mental health support system. This is something that John was also talking about, and is also the focus of the Society of Digital Psychiatry, is to introduce the term of digital navigator. I played the role of digital navigator over the last 4 years. I continue to do so. And what I see is there has to be a bridge between the human and and technology, which also helps the clinician down the protocol stage. And digital navigator will help the patient onboard the app, troubleshoot the issues, help with engagement, follow up with them, help them in between visits, improving digital literacy, improving engagement, and improving the overall quality of the data, which makes it a good enough insight for the clinician to use to either alter treatments or to make any adjustments based on their treatment plans. One of the very recent publications that we have done this year, which has just come out, is on the various aspects a DN can help the clinician, the technology, the patient, etc. I will share a link of this in the chat after I finish my talk. After we established that digital phenotyping is feasible and people engage with it with the help of a digital navigator, we recently got funded again to test whether remote cognition is possible, and can it replace burdensome in-person testing in patients with schizophrenia. This will establish a path for scalable cognitive assessments across LMICs in high-income countries. And over the last 6 months to 8 months, we have been successful to say that yes, remote cognition is possible in both the settings using the MindLamp app. And we have published our findings in one of the papers that I'll share after this talk. And it brings me to the most important point, is that the models that we have been researching, although it is related to digital phenotyping, it very well adapts to AI as well, is that it works both in Western and Eastern context, in terms of that there has to be a local adaptation of any technology that we use in India or in any other LMIC when we adapt it from the West, and a hybrid model support that is using a hybrid model of care that is using a digital navigator as a support person that bridges the gaps between all the three stakeholders. Digital clinic models is something that I would like to talk about in my remaining time. A digital clinic model is a system that has been pioneered by Dr. Doris's team at BIDMC, where the regular pharmacological care is supported by a digital tool and a digital navigator, which helps the patient use a tool with the help of a digital navigator, and also access traditional care in a long-term timeline. This is not exactly what we do here in India and what we aim to do, but we want to adapt the digital clinic model in an LMIC context like India. And why do we want to do that? The reasons are very clearly available on the screen. We have a huge treatment gap. We have limited specialists, and I love to quote one of my colleagues that I work with, where he says that to meet the current treatment gap demand that we have, or the workforce demand that we have, it will take us 72 years to build that workforce to cover the current treatment gap. And hence digital tools in the digital clinic model is very key to our success, or the aim of bridging a treatment gap. There's problems with digital literacy, clinicians are overburdened, etc. But the model that we want to establish here, as we've been trying to, is where the patient a patient's care can be augmented by digital tools with the support of a digital navigators, leading to a richer data, a more high-level clinician insights, and also long-term continuity of care. How this model will address the challenges that I've mentioned before is that it'll create a task-shifted workforce, which is digital navigators. how they will be trained. The Society of Digital Psychiatry is going to help put out some guidelines on the digital navigator trainings. And we are trying to adapt it to all the local settings that we want to use it to, using low-cost digital tools, offering a scalable hybrid care, leveraging mobile phones, and generating local data to guide policy and scale up, ensuring ethical and safe digital integration with standards. Because yes, we do have a model that works, but how do we know that it is safe to work with is another aim that we wish to fulfill by working with app evaluation frameworks that we have currently available, such as the APA app evaluation model. There is the WHO digital health guidelines. India is also coming up with their DPDPA Act, which is Digital Personal Data Protection Act, where we are coming up with rules and guidelines on how somebody's personal health information has to be stored and handled by third-party apps. We also have a lot of benchmarks coming up for LLMs and for ethical AIs that we want to deploy to our systems. All in all, the goal is that yes, we do want AI in an LMIC context, but it cannot be a copy paste of what we see in the West. It has to be very context aware of where we are deploying it to. It has to be very localized to the culture that it is being deployed to. And the only way forward that we see from our research and by talking to patients is hybrid models of care. In its standalone, neither was the digital tools working very efficiently, neither can the AI work very efficiently. And standalone models is not something that is suited to today's requirements. So the more we research, the more we know that digital navigators are going to be the reason why AI becomes successful in the future. And lastly, more funding from national and international grants and collaborations are the only way where we can take a jump from the pilot phase to a real world clinical implementation phase. And we do see long-term results being applied to real care. So thank you.
Soumya, a question I had for you was, can you explain in more detail, is AI a digital navigator a person or an AI? Can you explain that in like 30 seconds or in a minute?
Digital navigator is definitely not an AI. It is the human support that bridges the AI and the patient. So, for example, if somebody is onboarded to a tool which delivers, or an app that delivers AI-led CBT programs to a patient, and how will the patient be onboarded? The digital navigator takes care of it. How will the patient troubleshoot issues? The DN takes care of it. How will the patient discuss the progress with the digital tool with their clinicians, or want to adapt to it, want to change, want to discuss the feedback that is coming from the tool? The digital navigator helps them to schedule those discussions with the clinicians. And all in all, how does the clinician know that the tool that that their patient is using is working for them? The digital navigator helps take that insights out of the app and share it with the clinician. So the digital navigator is not the AI, rather the bridge between the AI, the patient, and the clinician, if this answers the question.
Yeah, thank you, Soumya, for clarifying that it's a person and not an AI.
Thank you, Soumya. I think these messages resonate probably for every country around the world too, that digital tools alone don't seem to be the solution. Even AI alone doesn't seem to be a solution. We agree we don't have more clinicians, but maybe digital navigators bridge that gap in a very novel way. To see you kind of pioneering it in India and sharing your experience is fascinating with that. So thank you.